Jean, I'm humbled. Thank you so much for that wonderful introduction. The Southwestern Surgical Congress has been a family to me for over the past 2 decades. There are so many individuals in this audience that are special to me, and no doubt I am missing many of you in these pictures. Each of you deserves recognition for your contributions to this organization, your enthusiasm for its growth, and the friendships that have developed at these meetings over the years. I have so many wonderful memories, and there have been many that have touched my life for the better. There are 4 members of the Southwestern Surgical to whom I would like to say a special thank you. First, to John Potts, who preceded me in the presidency. No email went unanswered, no question was too small. For his successful baton pass, I am so appreciative. To Ronnie Stewart, whose unwavering support and insightful advice was always on hand. If you ever find yourself in a bind, Ronnie would be there. Ken Murayama was the secretary-treasurer just before I entered the role. He helped me navigate some of the trickier moments of my leadership years, and for that, I am eternally grateful. Plus, his love for the Southwestern Surgical is truly infectious. And finally, Robert McIntyre, whose encouragement and belief in me over the past 2 decades never wavered. Thank you. Critical to the success of any academic surgeon is their network of support at their home institution. I've had many partners over the years, most of whom are in the audience today. Our group has seen its share of craziness over the past few years, and I'm grateful to each of you for your laughter, dedication, and incredible clinical care. Your patients, your current partners, and your families are lucky to have you. Turns out that getting all the surgeons in the same place at the same time is nearly impossible, so you see all the surgeons, or at least 5 of us, Ryan, Fred, Eric, Jean, and Chuck, as well as myself, as well as the latest 2 additions to our group, Barry and Mitch, in the pictures here, but not our breast surgical oncologist, Shama Jaiswal, or our pediatric surgeon, Dennis Bensard. 2 other people at Denver Health have been truly invaluable to me, our Susan Jackson, my nurse practitioner for over a decade, and our chief of neurosurgery, Kathy Beecham. One of my partners, Fred Parachi, has served as your program chair for this meeting. In this role, he has worked tirelessly to pull together what I think is a spectacular meeting. His organization, enthusiasm, and innovation have resulted in a terrific program. Plus, he tolerated my random ideas and input with aplomb. I've been fortunate to have fallen into step with some powerful role models and mentors over the years. As a fledgling medical student at UT Southwestern, Dr. Carrico provided me with encouragement and vision. He invited me to the annual meeting of the college to be UT Southwestern's representative to the medical student program, and with one meeting, I was hooked on academic medicine. His professionalism, leadership, and mere countenance provided a singular role model for me. Alden Harkin convinced me that Denver had over 300 days of sunshine a year and hence was the only place I should consider doing surgical training. As the chairman at the University of Colorado, he universally demonstrated that we could be more. He taught us how to ask questions, to seek answers, and to enjoy the path of learning. And I still hear his voice booming in the halls. Although I was supposed to return to Texas for my surgical career, how do you say no to this person? Simply put, you don't. There are not enough words to describe what an impact Gene has made on my career and, more importantly, on my life. He leads by example. He sets the bar high and propels those around him to live up to his example. His respect for others, his intellectual curiosity, and his sheer stamina are unparalleled. He encourages and he listens. He helped me develop my career and still serves as my sounding board. He is technically gifted and clinically astute, and he has taught me to be a great surgeon. And he is the first to remind me of the importance of family. I am forever in awe of his ability, dedication, and resilience. Thank you. 4 women have been inspirational to me over the past decade. Grace Ruzicki embodies grace and kindness coupled with amazing intelligence and unparalleled accomplishment. Roxy Albrecht is exemplary in her eloquence, fortitude, and character. Rosemary Kozar demonstrated academic success while embracing the role of wife and mother. She showed me it could be done. And Chris Kokenauer, who has been one of the women to pave the way for others, is one of the most caring people I know and became a big sister for me. To each of you, thank you for your example and your encouragement. And to my family, I would not be standing here today without them. To my in-laws, Bill and Maureen Burlew, I am so lucky that in marrying Paul, I gained an incredible second set of parents. Their unwavering support and love for me just means the world to me. And my parents. From my dad, I inherited my tenacity and my incredible work ethic. Although he's the hardest worker I know, he always made time for fun at the lake or on trips. Plus, he makes the best biscuits in town. My mom is simply unbelievable. So much of who I am today is thanks to her. I am thankful she always listened to me, and she still does. She's one of the smartest and most optimistic people I know, and she passed on her love of adventure and travel. My husband, Paul, simply makes life better every day. He is my best friend and the love of my life. Without him, I never would have had the joy of being a mom. Cothren is now a curious, joyful first grader. Seeing the world with her has been a blessing. I honestly can't quite believe my good fortune. My family's love, constant support, and encouragement enable me to stand up here to deliver my presidential address. Surgical education, lessons from Parenthood. When I began to think of this, my presidential address, for my surgical family, the Southwestern Surgical Congress, I wanted to somehow combine the two greatest influences in my life, the two most important things in my life, my love of surgical academia and educating residents with the joy of my family and being a mother. As I have stumbled along the path of parenthood and academia, I have noticed that there appear to be commonalities between the two. Although one might think that surgery and parenting have little in common, I'm surprised that at times they seem to be parallel worlds. So I thought it might be interesting to explore some of the common themes, the lessons that I have learned, the mistakes I have made, and the humor that I have found. You may recognize some of my path, and you definitely may have found better answers to the dilemmas, but I hope that each of you enjoys your own journey as much as I have enjoyed mine. The first and most obvious parallel in my two worlds is I'm only partially through the journey. I haven't reached retirement from surgery, and Cothren has yet to leave for college. So some might argue that all surgeons appear to work in some surgical or educator capacity well beyond typical retirement years. And similarly, my mom would say that her journey as a mom is still underway, especially when I get sick and call her for the best mommy prescribed remedy. In some ways, my journey as a surgical educator is further along than that of my parental role. In fact, some might argue that I really shouldn't give this talk until I have successfully parented a teenager. So for the sake of argument, I'm going to pretend that Cothren is 7 going on 14. First, how does one embark on this journey, and where is the formal education? Did anyone here ever really take a class or a course before becoming either a parent or a surgical educator? Nowhere during the span of medical school or surgical residency was I ever given any real instruction on how to educate others. We were each assumed to know how to teach someone else, whether it be as the chief resident taking the intern through their first lipoma resection or the surgical attending teaching residents the complex world of clinical care. Similarly, no one provided lectures on what you actually do when you come home from the hospital with that brand new baby. When you look at that tiny little life and ponder, well, now what do I do? How often have I questioned, where is the manual or the handbook or the something that is going to tell me what to do next? So how do you learn to do this? One option is you can model the behavior of others. Many of us parent based upon our own personal history. Dr. Benjamin Spock made the perhaps obvious notation: fathers and mothers don't really find out how to care for and manage children from books or lectures, though these may have value in answering specific questions and doubts. They learned the basics from the way they themselves were brought up while they were children. We all end up at least somewhat like our parents, especially in the way we deal with our children. So yes, I often think, what would my mom do in this situation? How would she have dealt with this? And at times I'm a little shocked when words come out of my mouth that sound exactly like my mother. I think this model reverberates in surgical training as well. Whether it's touted as the age-old surgeon as apprentice model or the simple refinement of the modern-day role model, I think we see it commonly. We see how our role models act and interact. We see them demonstrate techniques, foster learning, press for performance, and uphold standards. And we incorporate the behaviors that we found worked and that we admired. I think none of us would doubt the impact that role models and mentorship have on one's career. Each of us can look back upon our course in surgery and point to those who have been influential along the way. The importance of mentorship is well recognized in the surgical literature. Multiple publications have shown the influence of mentorship on both the decision to pursue a surgical career on the part of medical students, as well as for residents choosing their ultimate career specialization. Studies have demonstrated the role that mentors play in faculty development, networking, promotion, and retention. And residents, you play a pivotal role as well. Your impact on medical students can be significant. Residents who are effective educators and clinical teachers influence students in choosing surgery as a career. I remember being a sub-I at Parkland, and my chief resident on the trauma team seemed like a demigod to me. He held teaching conferences, critiqued our work, taught in the operating room, involved the team, and recognized the fundamental role that we played in the workings of the service. He made us feel we were an important member of the team, and as a result, we never complained about that 2 a.m. post-op check or the middle of the night blood draws that included blood cultures, because medical students actually did it back then. This was a recent exchange on the American College of Surgeons' online dialogues about role models and mentors. What I found particularly salient was 2 of the comments. The first comment was that having a single mentor is not truly realistic, but rather having a web or network of mentors was far more effective. The second comment was that you don't have to love your mentor. You simply have to respect them. You want a mentor who is going to challenge you. I thought this was particularly interesting and not really the way that I had thought about role models and mentors, but rather true. You've seen my network of mentors, many of whom have challenged me and provided guidance, and not all of their comments could necessarily be categorized as friendly, warm, or fuzzy. I was given some sage advice when I was on the verge of becoming an attending that echoes this sentiment. The words of wisdom you see here, which came from Robert McIntyre during the final days of my chief resident year, was a compiled list of 15 items for the emerging attending. And at the top of the list was the statement, "It's not your job to be the resident's friend." The purpose of that statement, I believe, was not to discourage friendliness, but to encourage the role of teacher and advisor, which can entail tough lessons, difficult feedback, and criticisms. The surgical educator is there to foster learning and growth while providing excellent clinical care. How often does this sentiment echo in Parenthood? In the famous words of none other than Charles Barkley, and I know you're all stunned, I'm quoting a basketball icon at this point, I think your biggest problem is parents are so concerned with being friends with their kids. You're not their friend, you're their parent. And in case one wonders what that entails, Nora Ephron had some choice words. When your children are teenagers, it's important to have a dog so that someone in the house is happy to see you. I think many of us as surgical educators find that some of the toughest lessons and the most formative learning happens for residents in high-stress cases or on a challenging rotation. Over the years, I've had former residents email me once they were established in practice, thanking me for those tough lessons. They may not have liked me or the rotation at the time, but often they recognize they became better surgeons due to that experience. For those that are older in the audience, reach out to those who are younger. For those who are younger, remember that your mentors don't need to be in the same department or even in the same institution or state. So I encourage each of you to take the time. Your impact can be profound. I received an email from a former resident several months ago with this quotation attached to it. I want to inspire people. I want someone to look at me and say, because of you, I didn't give up. I now have it hanging on my bulletin board in my office. I placed it there to remind me that at times we forget the impact that we have and how lasting it can be. And it reminds me how paramount it is to take the time. As Dr. Grace Ruzicki quoted in her presidential address to the Western Trauma Association, we must acknowledge that the most important, indeed the only thing that we have to offer our students is ourselves. Everything else they can read in a book. So back to my original question, how do you learn to do this? Another option for how we learn to teach as well as how we learn to parent is through trial and error. Anyone who's been up with a crying child at 1 in the morning is incredibly familiar with this approach. You begin to realize there are many different ways to accomplish the same end point. You have to refine your techniques over time. What works in some situations doesn't work in other situations, and there's not necessarily always a right answer. There isn't only one way. One of the clearest examples for this for me was in my trial and error experience in teaching junior residents how to repair an inguinal hernia. This case always appears to be relegated to the easy category, and yet I think all of us might agree it's not as easy as one might think. After several years of trial and error in my approach to teaching this easy case filled with seemingly complex anatomy, I devised a simple conceptual method for the procedure entitled the U and the sushi roll. I approach every inguinal hernia repair with this paradigm. Teaching with this technique, I think, enables the residents to understand the components of the procedure, incorporate them into their armamentarium, and eventually enables them to perform the procedure independently, regardless of how big or confusing that hernia ends up being. Over the past 2 decades, we have seen a marked increase in the available resources. On the parenting front, there are now an untold number of books, webcasts, YouTube videos, and parenting blogs that offer up guidance and helpful hints. In the surgical realm, there is now much more of a focus on professional development. At the individual level, educators receive feedback and important input on their teaching style and impact. Resident evaluations are collated and reviewed by division chiefs and go into the records of the faculty. On the more global level for the faculty and for surgical residency programs, there is a wealth of information published on different teaching techniques. Suggested options to improve resident education include coaching, debriefing, and deliberate practice. And more residency programs now incorporate formal training on teaching skills. At the national level, the American College of Surgeons sponsors formal training in their Surgeons as Educators course, as well as in their Residents as Teachers and Leaders offering. Learning to become a surgical educator and how to be most effective in this role could really monopolize my entire presentation, but I'd like to get back to the original tenet of my talk, surgical education lessons from Parenthood, and focus on some of the tips and tactics that I've learned from parenting that might apply to educating students and residents. The first, provide a framework. In my opinion, as both a parent and as a surgical educator, this concept is one of the most critical. The idea crystallized in my mind one afternoon on a conference call. I was presenting some ideas for a national educational curriculum for the acute care surgery fellowship programs. The proposed curriculum would complement our recently redesigned operative curriculum. Admittedly, I was a little trepidatious because my ideas for the curriculum really didn't follow some of the classic models already adapted, but was centered around a more senior level discussion of the variety of complex thoracic and vascular topics that acute care surgery fellowships are tasked with teaching. And then I wanted to combine those didactics with expert commentary from the national leaders in the organization. As you can imagine with any group, there was a healthy conversation that followed, but it was the single voice that argued against having any curriculum that surprised me. Was this curriculum really necessary? The individual suggested that fellows should simply be told to go read. Well, after I got off the call, I thought to myself, well, go read what? Where? And with what emphasis? I felt like he was really telling us to tell our fellows, just go learn surgery. That might be a little analogous to me telling Cothren, just go learn to ride a bike. You can figure it out. The bunny slippers notwithstanding, of course. Each week, I hold a Friday morning chapter club. We pick a chapter out of the trauma textbook and run through different trauma scenarios in an oral boards type of format. We start with a framework of learning and provide context. For example, if you read it closely, the splenic injury chapter doesn't really tell you in black and white when to perform a splenectomy. So Friday mornings enables me to provide a framework for the process of learning. What's important, what's germane, what deserves emphasis, and what is less relevant. What should be taken with a grain of salt? We talk through the gray zones, the caveats, and the considerations in the complex patient. The first official framework for surgical education was actually introduced over 100 years ago in 1890 by Dr. Halstead, who created the surgical residency program as a paradigm of education. The Halstedian training model is firmly entrenched in many of us. See one, do one, teach one was a mantra that often echoed in the hallways when I was a resident. This model presumes that increasing amounts of authority and responsibility results in surgical autonomy. The term we now hear in the hallways is graduated authority or graduated responsibility via the surgical milestones, but the concept is the same. This progression in authority and responsibility parallels the essential structures of learning. As you see in this published diagram, learning is stimulated by graduated involvement. The amount of retention by the individual, seen here as a percentage in parenthesis, increases as you become more actively involved, either mentally or physically, in the process. Each of us has progressed through this framework of learning, from receiving a lecture and reading about a case, to watching a fellow resident do a case, to doing it ourselves. While practice doing something results in a significant amount of learning, the most influential moment on the learning process is teaching someone else how to do it. For the surgical resident, reading a surgical textbook results in perhaps marginal retention compared to either performing a procedure or teaching a junior resident how to do it. This is a good reminder to each of us that allowing the senior residents to teach their juniors is a critical component of the educational process. This learning progression is common in our children as well. If Cothren is learning a new piece on the piano, she starts by watching her piano teacher, then moves to practicing the piece herself, and finally, she teaches it to mom. Providing a framework applies not only to the information that needs to be acquired, but also to one's expectations of the individual. For children, this is commonly referred to as setting boundaries or providing structure. The parent explains the expectations and the associated consequence of particular actions. There are many parenting books that talk about the importance of a consistent routine and the fact that children do better with structure and clear limits. In fact, one of the best titled parenting books that I came across while doing my research for this talk, entitled The 7 Worst Things That Good Parents Can Do, lists number 6 on their list of the worst thing that you can do as fail to give your child structure. Even the CDC, of all entities, reports in their list of parenting essentials the webpage entitled Creating Structure and Rules. I would propose that the same is true for surgical trainees. How many of you sit down at the beginning of a rotation with your residents and outline your expectations? I think each of us has expectations of our house staff that are individualized by postgraduate year of training. This may range from preparation for the OR, expectations on rounding, performance in the trauma bay, and behavioral interactions with patients and families. And each of us can add others to the list. But I would argue that if we don't make clear our expectations of the resident and provide a framework for their rotation, then our subsequent judgment of their performance may not be fairly adjudicated. By setting the expectation and highlighting the consequences, we can all be on the same page. Additionally, if you set the framework of expectations, students report that this simplifies and improves teaching. Without known expectations, students are more likely to shy away from active participation. So encourage engagement with clearly stated expectations for students and residents, whether in the OR, on rounds, or in clinic. Sometimes this experiential framework is termed creating a culture. One such framework that was provided by Cothren's kindergarten teacher and was posted on her bulletin board. Is it safe? Is it kind? Is it my best work? These words and this framework could easily apply to my day-to-day life in the hospital. So simple, and yet it incorporates the fundamentals. Each of us has the ability to set the framework for our group. Amy Goldberg, when she became the chair at Temple in Philadelphia, had the following framework for her vision of the Department of Surgery: teamwork, optimism, professionalism, quality. In these 4 words, she set the expectations for her surgical colleagues. As one looks around, we see the visions and frameworks wherever we look. At Denver Health, we provide level 1 care for all. At St. Mary's Hall, which I attended from Montessori through high school, the framework was teach us delight in simple things. Each institution, each department, each realm of education provides the framework for that environment. If I hark back to those words of Mrs. O's, one can find echoes in the oath that each of us takes when we become physicians. In the body of the Hippocratic Oath, we find the following lines: I will not be ashamed to say, I know not, nor will I fail to call in my colleagues when the skills of another are needed. I will remember that there is an art to medicine, and that warmth, sympathy, and understanding may outweigh the surgeon's knife. I swear to fulfill, to the best of my ability and judgment, this covenant. As we establish the framework, it is incumbent upon us to set the example. We see this day in and day out. Children model and even imitate the behavior that is demonstrated around them. Earlier, I spoke about the importance of taking the time to be a role model. In being that role model, you set the example. You not only talk the proverbial talk, but you walk the walk. And it's okay to set the bar high. In the parenting book, 8 Keys to Old School Parenting, it encourages that you set high expectations and help children live up to those standards. One study that looked at the qualities of effective leaders in the operating room reported that transformational leaders, as compared to transactional leaders, access the intrinsic motivation of their team members. They intellectually stimulate them to continue achieving beyond expectations. They articulate an overarching vision and foster team identification with it. By demonstrating a high moral standard, these leaders gain the respect and trust of their team and inspire people to transcend self-interest for the good of the group. As a result, transformational leaders have a tenfold increase in supportive behaviors in the operating room, with a concordant increase in effectiveness, safety, and clinical goal achievements. Another critical element of leadership is accountability. One must take responsibility for one's decisions and outcomes, even if the outcomes are not stellar. For those of you who have not read the classic book Forgive and Remember, I encourage you to hop on your smartphone and order it. It speaks of the fundamentals of accountability, as surgeons have a ceaseless striving for perfection. I think part of the inherent ability of any effective surgeon, or for that matter, any parent, comes from their communication. It's not just what we say, it's how we say it. It's the tone of voice as well as the inflection. Often, if one talks in a neutral tone, you're more likely to get your message across. The prime example of this, calm communication, was on display in Cothren's first grade classroom. There were 22 students clamoring about, and without missing a beat, and in the most calm and measured voice I think I've ever heard, her teacher, Miss McPhee, managed to have all 22 of them sitting in a circle on the floor for sharing time. And she managed it with one sentence. Although I've been less effective in my ability to use the McPhee communication style while in the trauma bay for a trauma activation, I am trying. Part of communication is being clear in your message and never making assumptions. We also have to recognize and remember that communication goes both ways. You want to foster an environment which promotes accessibility and approachability. Within an established framework, the next arena of engagement is to promote autonomy. Clearly, every parent's dream is to successfully raise a child to adulthood, and every educator's goal is to train a resident so that they become autonomous. That's the purpose of the educational framework, so that they can venture into the world on their own. So how do we take those steps towards full autonomy? How do we support and promote individual progress towards that goal? How do we catalyze that growth? For some, it is simply called parenting. For others, it is called appropriate supervision, which reflects back on my prior comments on graduated responsibility. A popular model of instruction to promote operative independence is this model. With a graduated process of instruction through show and tell, to smart help, where an attending helps guide the resident through key aspects of the case, to dumb help, where the resident performs the key aspects with the attending providing only passive help, and finally to the no-help stage, where the resident instructs another how to do the case. But at times, there needs to be the simple reminder that sometimes you just have to let them do it themselves. It may not look quite the way you wanted or turn out the way that you envisioned, but the sense of personal accomplishment will more than compensate. You have to let the 4-year-old dress themselves. You let the first graders resolve the conflict over who gets to do something first, and you have to let the third-year residents struggle with the exposure and the mobilization. We as parents and educators could do it for them and make it oh so much easier, but otherwise, when will they ever really learn? One parenting blog referred to this tendency as the fact that we rescue too soon. Without using the mental muscles of conflict resolution, problem solving, creative thinking, and the like, one will never develop the means. So just as I try to hold my tongue when I see a brewing disagreement amongst children, or think there's a better way to solve a 5-year-old's problems, or a faster way of doing something in the operating room, sometimes I need to remember patience. I need to allow each of them to do it themselves, while ultimately keeping the situation safe. They need to try to figure it out and learn from the process. Taking calculated risks is part of this process of growing up. The interplay of risk and achievement is a critical aspect of one's identity and confidence. Many a parenting tome reports that if we remove risks, children mature with a high level of arrogance and a low amount of self-esteem. Achieving things that are meaningful through actual experience rather than watching a YouTube video results in self-confidence and autonomy. Part of the pathway to autonomy is learning how to navigate failure. One of the email blasts from the principal at Cothren's school pointed out that although we should celebrate children's achievements, it's much more important to parent and educate them through their missteps and their failures. I have to admit, I really hadn't thought that much about this specific concept until that email stated it in black and white. We have to allow them to make mistakes and learn from failure. So how do our trainees learn to deal with failure and not shrink from future action? How do you encourage others to deal with a setback with courage and not become defeated? How do you help them recognize that mistakes are an opportunity to learn? Encouraging their individual fortitude, empathy, and can-do attitude is a critical element. This book is an interesting example of how we can approach challenges, how we can foster resilience in our children and in our surgical trainees, how we can encourage them to approach the obstacles with an "I can do this, I can overcome this" attitude. It discusses the importance of being empathic and using effective communication. It encourages identification of areas of competency for reinforcement while providing the opportunity to learn from one's mistakes. And finally, it encourages problem solving and decision making. When Cothren came home from school one day at the age of 5 and said they were learning about and focusing on having grit, I knew that I truly loved her school. I thought, grit, what a terrific concept. And no, Jean and I did not coordinate this, I'll let you know. What a terrific concept. Only subsequent to that fateful day in preschool did I understand that there was an entire arena of thought on this topic promulgated by Angela Duckworth, the sociologist. As she explains, grit is passion and perseverance for very long-term goals. Grit is having stamina. Grit is sticking with your future day in and day out, not just for the week, not just for the month, but for years, and working really hard to make that a reality. What is interesting is that grit is not really about one's natural talent or ability, but about one's effort. And even more fascinating in these studies about grit is that it emerged as the single predictor of success, superseding IQ, health, looks, and social intelligence. Turns out, I'm not the only surgeon that thought of the role of grit in surgical education. Just last month, this article was published in the American Journal of Surgery. It demonstrates that grit is a reliable measure that is associated with psychological well-being and appears to be predictive of attrition risk. So how do we ensure these qualities, things like grit, resilience, self-confidence, persistence, conscientiousness, and even curiosity, are part of the educational landscape if they are inexorably linked to success? Although you might believe these are inborn qualities of the individual, these character traits are in fact malleable. Two of the thought provokers in the realm, Seligman and Peterson, identify that these are strengths, are skills that you can learn, practice, and teach. And there are a multitude of other publications that capitalize on this research and encourage the development of this construct. I think it's critical that we focus on these elements in surgical education. With the prevalence of burnout and depersonalization in our surgical culture, and the recognition that the physician may become the second victim following medical error, resilience, communication, and support play a fundamental role. Fostering emotional intelligence in our trainees, as well as in our children, promotes self-awareness, flexibility, and situational awareness, and improves communication. Encouraging resilience is protective as it has a documented inverse relationship with burnout. So what can we do? One of the key buzzwords of late in surgical education is providing feedback to the residents. One of the critical elements of any curriculum is formative assessment and feedback. Many surgical educators may feel that the conversation in the OR during a case is filled with feedback for the resident. But careful evaluation of your banter might reveal that there is much more instruction than feedback. The attending might tell the resident how to orient the needle holder, tie down a suture, develop a new tissue plane, or more effectively retract an organ. They might discuss the pitfalls that they've seen, complications of which one should be wary, and technical mishaps that have occurred to past residents in precisely this situation. My residents often hear these anecdotes from me, the doom and gloom of, oh, you have to be careful because X has happened here, or be mindful of Y happening post-op. But this instruction should be clearly delineated from the actual feedback to the resident of how they are performing the components of the procedure. These comments and criticisms allow the residents to fine-tune their skills, rethink their decision-making, identify their zones of competence, and work on their areas of weakness. The key point for educators is providing specific feedback on the resident's technique or decision-making in real time. Different organizations have incorporated a variety of techniques in this vein. Some training programs mandate a written process where an attending fills out a paper form at the end of an operative case, documenting the relative degrees of the resident's competence during the case. Some use a specific tool entitled the Surgical Procedure Feedback Rubric, which breaks down a particular operation into components consisting of both surgical reasoning as well as intraoperative technical elements. Residents are then graded on each component as needs attention, developing, or achieving. Personally, I have to say that this rubric held some appeal for me when I read of it, as it sounded exactly like the grading scale that my first grader has. Other faculty have a less formal process of providing feedback. For example, a huddle at the end of the case enables the attending to discuss what the resident did well, specific areas for improvement, and what lessons were learned during the operation. Another process that has demonstrated efficacy in optimizing experiential learning is preoperative briefing followed by postoperative debriefing. This targeted teaching can be individualized for each case, but promotes active integration of both the faculty and the resident and increases critical feedback. Other options used in the formative assessment and feedback process include mock oral examinations and the ACGME milestones. And so this gives me the quick opportunity to remind you of our new Southwestern Surgical Initiative mock oral boards for the chief residents at our annual meeting. Each of these options enables the resident to incorporate feedback on their educational progress, perform their own self-evaluation, and reflect upon areas for future improvement. Similarly, these programs allow the faculty to become more involved in the feedback process and permits a more objective tracking of the residents through their training. Regardless of the specific option utilized, immediate feedback is critical for those acquiring new skills. A key component of providing feedback is recognizing it's not personal. What I mean by this is that the feedback should be about the specific performance metric or the behavior rather than about the individual themselves as a person. In parenting, we are reminded that when reprimanding a child, you should focus on the bad behavior, not that the child is a bad person. For example, you might say, that was a stupid decision to paint the dog, but not, you must be stupid to make that decision. This particular method of giving feedback is critical in surgery as well. As I tell my residents on ICU rounds, the criticism isn't personal. Doesn't mean that they're a bad person, they simply made a suboptimal choice or a decision that didn't turn out so well for the patient. One can be upset, frustrated, or even mad about actions or decisions, but focus on the specific behavior and not on the individual. When providing feedback, it should provide concrete examples. General, non-specific wording is simply unhelpful or can be easily ignored. Instead of saying, resident X can't operate, one might say, resident X needs to work on their fascial closure technique, or resident Y needs to work on the dissection of the triangle of Callot. And sometimes, one has to point out that it is, in fact, feedback. While faculty feel they are consistently giving feedback over 90% of the time, residents report receiving feedback only 30% of the time. So as my partners demonstrate, sometimes you have to be pointed as a surgical educator to remind trainees that they are, in fact, receiving feedback. I'd like to close with some practical suggestions that simply didn't fit into my talk elsewhere. Due to time constraints, they'll be bulleted, quick, and to the point. Always keep your eye on the task at hand. Don't forget the importance of physical diagnosis skills. Remember to always be prepared. Wear your eye protection. Don't expect others to always follow your lead. Encourage curiosity. You will need a lot of things in your surgical armamentarium. Listen to the discussion at M&M and seek the words of wisdom from senior educators. Never stop learning and adapting. Develop a love of reading. Sometimes you just have to sit at the patient's bedside. Friends and family can always give you a lift. Teachers and parents are people too. They aren't perfect. They are full of frustrations and foibles and feelings. Do the job for the beauty of the job, not for the accolades. Unlike kindergarten soccer, there isn't always a trophy at the end of the day. Sleep when you can. And occasionally, you have to watch your back. Surgery and parenting have undergone changes over the past 2 decades. We now have helicopter parents, and similarly, attendings are now present throughout the entire operation. Faculty no longer relegate care of patients to the house staff with minimal cursory involvement, and children are no longer told to simply go play outside in the neighborhood but be home in time for dinner. If we look back hundreds of years at the original version of the Hippocratic Oath, it reminds us to hold my teacher in this art equal to my own parents. The evolution of surgical education has elements that are the same and somehow different. And I suppose that reminds us that the only constant in life is change. So you should enjoy the journey, because in the journey lies the reward. The journey of parenting and of surgery is humbling. You will have moments of pride, of exhilaration, and of frustration. There are times it will be easier said than done, and yet it is the most wonderfully exhausting thing you will ever do. And when you least expect it, you will be congratulated, or hugged, or thanked, or you will simply get a smile. My final lesson from Parenthood: trust that you have taught them well, and you have to let them go. They will hear your voice out there in the real world. It will echo and guide them. And kids, don't forget to call home and let your parents, surgical or familial, let them know that you're doing okay. The Southwestern Surgical has been my surgical family for the past 2 decades. I am truly honored to have been your president this past year. Thank you.